Good evening, all the aspirants present here.
Good evening.
Good evening. We are going to start our session. So, more students will be joining us soon. So, today's topic is metabolic diseases, and the speaker that we have here is Dr. Sujay Samanta, who is Associate Staff Associate in Critical Care Medicine and Division in Cleveland Clinic, Abu Dhabi, UAE. Hello, sir.
Hi, good evening to all of you.
Good evening, sir. So you may start the session. More students will be joining us soon, and it is going to be an interactive session. Thank you.
So we are discussing about the maple syrup urine disease. So next slide, go to the next slide. We already discussed this thing. Yeah, in this pathway, we can see that there is three branch chain amino acid which are being initially the branch chain amino transferase. The first enzyme is amino transferase, which is basically producing the keto as all these this branch chain initial acid alpha keto amino acid is formed initial metabolites. Then the next is the dehydrogenase, which is actually after that pathway it will come the acetyl CoA or succinyl CoA, the final metabolites for this. The either it will go into Krebs cycle or the other cycles. So in this is the enzyme deficient dehydrogenase complex which cause this maple syrup urine disease. Next slide, please. Okay, so diagnosis is basically the elevated level of branch chain amino acid and their immediate metabolites, and also the lactate pyruvate will be as a bypass. It will be elevated, and this will be detected, as I said, by different chromatography techniques or by the biochemical test. And some we can even detect the enzyme in the if the family history is there in the prenatal as in the amino site or chorionovilla cells as well. Even after the newborn, we can screen this with this some mass spectrometry technique. The enzyme can be assessed and we can detect the classic that maple syrup urine disease as well. Next slide. So management, nothing much is there. Basically, dietary restriction of the branch and amino acid has to be done, and there are several formula feed are there. So we that has to be given, and we can't eat a medical food. So it's a nutritional medical therapy, and it has to be maintained throughout the life because this is the irreversible enzyme. There is nothing we can change the enzyme as a supplement to metabolize this amino acid. And sometimes the thiamine, some response are there, so thiamine trial can be given. And in some of the patients of maple syrup urine disease, in addition to the dietary therapy, and but this is if the thiamine is responsive, then it is very good. So we can continue the thiamine therapy along with the dietary therapy these cases. And whenever there will be some metabolic decompensation or anything, this is very serious issue. So and this has to be to be dealt with very treated aggressively. And so we have to be careful not giving those patients with any sort of branch and amino acid containing food, basically. Next slide, please. So next topic is phenylketonuria. So this is basically aromatic amino acid phenylalanine. They are this metabolism problem. Here also the enzyme deficiency is phenylalanine hydroxylase. So this hydroxylase enzyme is deficient. So if we don't treat this, what will happen? There will be again the metabolites will be accumulated in the body, and it will have impact in different when it will be deposition or it will be in the different organ. It will have a deposition, or the effect itself will have some mostly neurological symptoms, and also the skin problem as well. So the major cases of phenylketonuria is caused by this hydroxylase enzyme deficiency, and so it will result in the blood and the urine concentration of phenylalanine and its metabolites like phenylacetate, phenylactate. So phenylalanine itself also, the immediate metabolites like the phenyl acetate or the phenyl lactate will be increased in the blood and urine. And but tyrosine is the next step, next metabolites from the phenylalanine, so it will be normal, and most of the cases it will be normal. In some of the cases there will be other, like there is an enzyme which is like in 2% of cases, this hyper phenylalaninemia defect due to the tetrahydropitin hydrogen metabolism. This is actually cofactor in the hydroxylation pathway. So if the cofactor, either the enzyme deficiency or the cofactor deficiency, which will have the defect in the metabolism of phenylalanine, and ultimately the phenylalanine and its metabolites will be increased, and those will be secreted in the urine, and also it will be elevated level in the plasma. So in there is enzyme deficiency, it's up to the different variable degree are there. Like if the complete deficiency are there, in such cases the phenylalanine concentration will be very high in the serum. It will be very high, like greater than 1200 micromillimole per liter, and urine also will be very elevated. But if the some enzyme activity is there, so depend on that, there will be we can and the phenylalanine concentration will be different variable amount. We can categorize it mild phenylketonuria or moderate ketonuria, like that. Next slide, please. So here also the main management is the dietary restriction of the phenylalanine, because we don't have the enzyme to metabolize this amino acid. So we should restrict the intake of this phenylalanine. And there are some enzymes are there, like this uh, pegvaliase, that is approved for the adult patient with PKU. But the mainstay of therapy is the dietary therapy, dietary restriction. Basically, it is the initial therapy we should always be implemented immediately. And sometime, as I said, that there is a fact, the bihapterin, this cofactor deficiency also can have some effect in the metabolism of the phenylalanine. So that's also one of the reasons, but very minor cases. And so the main therapy is the dietary restriction. And some pharmacotherapy is that if the patient has a mild to moderate phenylketonuria, in that cases, like synthetic, that cofactor BH4 is available, which is called sapropotin. So that can also be in as an adjunct to the dietary therapy, can be added to mild to moderate PKU cases. So that's the point. And another thing is, for the patient with this bihaptotin 4 cofactor deficiency, we have deficient neurotransmitter precursor like L-dopa, carbidopa, and serotonin are also provided. These are to improve the neurological symptoms. Actually, as I said, it's the phenylalanine, its metabolites have a lot of neurological symptoms. So these are these precursors will have the neurological symptoms will be less. And the monitoring of the blood concentration, as I said, phenylalanine and tyrosine should be monitored frequently, and especially during the infancy. And out that once we ensure the dietary management, most of the things will be the symptoms will be resolved of the this phenylketonuria, except if it is the cognitive impairment already happened, then that usually doesn't reverse. Next slide. Next topic is alkaptonuria. So it is an autosomal recessive disorder, and the basic deficiency is the homogenesic acid, that dioxygenase enzymes is the defective enzyme here, and which is basically the tyrosine metabolism's pathway. It's a defect. So this enzymes, this homogenetic acid dioxygenase, basically ultimately will be impact on that homogenetic acid will not be metabolized. So it will be again will be accumulated in the body, and then it will be deposited in the different connective tissues. So when this homogentic acid polymerizes, it's kind of a pigment form as a pigment when the more molecules join together and polymerizes. So it will mainly deposition through this connective tissue and in the cartilages, in the joints, in the and even in the sometime in the eyes, in the sclera itself. So this pigment, when it involves the large joint like the lumbosacral joints and even the disc itself, so it will symptom as a osteoarthritis or arthritis kind of things, and sometime it will be like ankylosis, joint stiffness will happen. Inflammatory as well as non-inflammatory ankylosis can also happen. And now how will you look like if it is coming in the urine? It's normally freshly it will, it's a normal urine. But when you kept it for some time, so the urine become dark brown or the black color. So because this homogentic acid, it's also oxidized and make it it's a black color. So it's also called, it's a black urine disease. So level of this homogentic acid in the blood and the urine and the tissue samples are the basically diagnosis. So diagnosis is a quantitative measurements we can do in the urine, and also we can do the gene involved in the HGD gene. We can do the gene detection as well. In this case, the tyrosine level are usually normal. So there is no approved treatment of this alkaptonuria, although there is a enzyme called basically the, some therapy is there like nitisinone. There is an agent which inhibit the second enzyme of tyrosine catabolic pathway, which is the immediate the prior metabolic pathway. If we that basically uh, decrease the production of homogentic acid itself. So this way that involved as a treatment for alkaptonuria, and which causes basically the decreased urinary and blood homogentic acid level. So this agent can be used, but I think this is still either like in the studies, not even in the clinical effective, I mean no clinical effective study still yet for the clinical use. Next slide please. So we can easily see here in this is the phenylalanine from their tyrosine form, and here some hydroxyphenyl pyruvic acid from tyrosine to 4-hydroxyphenyl pyruvic acid is there. Here is the medicine which is the investigational therapy here. If it block the formation of homogentic acid, so this way there will be less homogentic acid which will not be basically deposited in the body, and the I mean the high level of blood and the other connective tissue. So this is the way this drug can affect. And alkaptonuria happen when this homogentic acid dioxygenase enzymes which is deficient here, which will lead to the homogentic acid level accumulation in the body, which is the basic mechanism of alkaptonuria. Next. So here, this slide basically just kept different organic aciduria and maple syrup urine and even the other metabolic inborn errors, with just to see how is the clinical biochemical findings to compare between them. So here we can see basically just to show that hyperammonemia will be happen. If the hyperammonemia pattern will come, this will mostly fit with the urea cycle defect, because ammonia is metabolized in the liver to make urea, and there will be if the urea cycle different enzymes are deficient, the hyperammonia picture will come. So this you have to identify the pattern of illness and the pattern of biochemical finding which will fit to the disease. So hyperammonemia will be in the urea cycle defect. And if we see the metabolic acidosis, it is basically with all the organic acidemias it will come. And if we see the respiratory alkalosis, again it is in the urea cycle disorders. And hypoglycemia will be more of the carbohydrate metabolism problem or the fatty oxidation disorders. So these two are the basically patient hypoglycemic episodes will come. So these things are more there. And lactic acidosis will come either in the carbohydrate metabolism and even in the with the this amino acid problem, and including the mitochondrial disorder. So major lactic acidosis is higher is in the mitochondrial disease and also the carbohydrate metabolism, and in some cases of amino acid metabolism, because the acetyl CoA formation will not be there, so it will be the alternative pathway will be there, so lactic acidosis will be increased. So pattern detection is important here. Next slide please. So in this slide, basically, I wanted to show that some clues from the urine, how to identify the inbound error of metabolism. So as just we saw in the before slide that in homogenetic in alkaptonuria, the urine will be black color. So in case of tryptophan metabolism problems, it will be blue color. If it is hemorrhagic something, it will come with a pink color. And in porphyria, we'll discuss in the next class. In the porphyria, it's kind of wine color urine. It's come. So there are other urine order also, and like maple syrup urine, this look like a maple syrup. And some tyrosinemia, it is cabbage like urine order. And in case of phenylketonuria, it is mousy order. So this order is also just to identify the diseases and the patterns very quickly, because these are the classical pictures, actually clinical pictures. So if you remember these things, so it will be easy to differentiate between the disease, even if you forget the enzymes. Next slide please.
So may I show the next slide?
Yes please. Okay, this picture basically, I this is the urea cycle pathway. So we see that here is the ammonia is there, and ammonia with the bicarbonate have basically form this we can see that it formed this citrulline, and then with the ornithine it will come citrulline to arginosuccinate, and then from there argine, and then finally the urea is formed. So here there are several defect, the enzymes deficiency will be there, and the urea cycle defect will be there. In this, basically the ammonia will be high, and the immediate when once the enzyme will be deficient, the immediate precursor the metabolite will be high. Please, next slide please. So here we can see there are some cases of ammonia, like in arginemia, the elevated plasma arginine will be, as I said, the enzyme will be deficient, so immediate precursor. So you need to know some of this urea cycle disorder, where the which product which the metabolite will be high, and that's depend on the which enzyme is deficient. So based on that, basically the metabolite will be high in the plasma, and that will lead to this, basically how will you detect the defect of this disease, or you can even detect the enzyme deficiency itself as well, through the metabolites or through the enzyme. So these are these some pattern of abnormalities I am just sharing. That's what will you get in these cases.